we only had 2 or 3 or 4 slides put together. We figured this is much more of a Q&A process. But this is Kristin Oelschlager, who is in our medical affairs group, who's overseeing the medical communications for your physicians, essentially. And her, in concert with Kristin Oelschlager, who runs the laboratory in Phoenix, are rolling out another growth of that. But the one thing I would say is that we didn't develop this test. It was developed by Dr. Harbour on the back of a large National Institutes of Health grant last decade. One of the things he wanted to do was to make sure that if it worked in terms of improving decision making, that it was available across the U.S. And so we'll do that for you. So we licensed it in, checked all of his work in our lab to make sure we got the same results, and then made available. And as I guess you heard this morning, we've had some evolution the last couple of years. This gene called PRAME wasn't originally seen as being important. It may still not be important, and I think that's part of the ongoing work. There's also been work looking at sort of gene mutations. So how do those fit into gene expression? So gene expression really is taking kind of a snapshot of your tumor. It's really a pattern recognition system. So if you think about fingerprinting or think about facial recognition in airports, that's essentially how this gene expression profile works. It looks at these 15 genes and how they're expressed, and then compares that to tumors of known outcomes. Mutations really look at what's going on with a certain gene, and at least in our case so far, the work that we've seen is that mutations don't seem to trump gene expression profiles in terms of accuracy, but they might add to it. And so one of the things that occurred earlier this year was Dr. Harbour received another large grant to look at essentially the next 5 years of being able to see if we go ahead and measure other things like mutations in certain genes, will that improve decision making? Maybe some of these might lead to targeted therapy opportunities down the road, et cetera. So that trial is kicking off just now, I guess, maybe a couple of quarters ago. That'll involve roughly 1,000 patients. Some of your peers may be involved in that, but we'll talk a bit about that. We'll turn it over to Kristin Oelschlager to talk through some of the dialogues. This should be just a free and open conversation, by the way, either now or later. So that background.
I'm going to repeat a little bit of what Derek said since some people just came in. So we really want this to be interactive and hear from you and your questions. So I'm just going to go through a few slides on how the gene expression profiling works, a little bit about the sequencing of mutations that we'll be offering soon, and then hear from you. So just to give you a little background about Castle as a company, we're a small molecular diagnostics company. We're about 70 people, and our corporate offices are based in Houston, Texas, or outside of Houston, Texas. And our laboratory, where all the sample processing happens, is in Phoenix. And so like Derek mentioned, the gene expression profile test for uveal melanoma, which is called DecisionDx-UM, was developed by Bill Harbour, who's now at Bascom Palmer. And so we licensed that from him in 2009. And so it's been available clinically through Castle since 2010. So for the last 7 years, and over 7,300 uveal melanoma patients have had the test performed. And with that, over 96% of those tests have been successful in the last 7 years. We also have a similar test for cutaneous melanoma. I'm not going to go into details about that, but it's similar. It gives you a class 1 or a class 2 risk, and this is for patients who have skin melanoma. So this is our laboratory, a few pictures of our laboratory in Phoenix. And actually, coincidentally, this woman here is Natalie, our PhD scientist in the lab, who actually runs the uveal melanoma samples. So really, this test was developed to help physicians determine how to manage patients with surveillance. So determining really at the molecular level from the biology of the tumor which patients are at a low risk for experiencing disease spread, which patients are at high risk, in order to tailor this, liver screenings, referrals to medical oncology, referrals to a clinical trial based on the biology of the tumor. So that was what Dr. Harbour had in mind when he developed the test. And here is how the test works. So the test is run off of the uveal melanoma tumor. So for about 90% of the cases that we receive, this is done from a biopsy that you usually would have at the time that your plaque is placed or proton beam clips are placed. And then we also can test for patients who have an enucleation. We can also test tumor tissue from that enucleation specimen that's preserved in a wax. And so those account for about 10% of our cases. So from that, we isolate the RNA, which is a nucleic acid. So it's the genetic material that tells us the levels of the RNA of these genes, tells us whether they're highly expressed, whether the gene is turned on and is really active, or if the expression levels, the RNA levels are low, that means the expression of that gene is low, it's turned off, or it's turned down. And so we look at 15 genes. And so that creates your gene expression profile, or sometimes people refer to this as your GEP. Then, like Derek said, we use an algorithm, a computer algorithm that actually compares each patient's GEP to a set of uveal melanoma cases that have long-term outcomes. So we know what happened with those patients. We know whether they had an aggressive tumor or a non-aggressive tumor. And so based on that comparison, we get either the class 1, which is the low risk, or class 2, which is the high risk. And then sort of as the science developed, Dr. Harbour identified that 2 of those genes out of the 15 helped to differentiate which is the lowest risk group, which is the class 1A, and which is the intermediate risk group, or the class 1B. So that's how that works. And please feel free to jump in with any questions as we go through this. So as of last year, Dr. Harbour had identified another gene. So the class 1A, class 1B designation was based just on the 15 genes. But then his lab more recently used newer technology to look across all the genes in the uveal melanoma cells and determine what else may indicate a higher risk of metastasis. So that's where PRAME came from. PRAME stands for preferentially expressed antigen in melanoma, so it was actually originally discovered in cutaneous melanoma, and it's normally not expressed in normal cells, normal adult cells, but in some cancers it can become more highly expressed, like sarcoma, leukemias, and as it turns out in uveal melanoma. And so what Dr. Harbour's lab identified was that uveal melanoma tumors that have PRAME expression, which is about a third, and I'll show you some statistics on that, that may actually elevate the risk. But the data is still maturing. Like Derek mentioned, there's a large study that just started to evaluate this prospectively, so that means on patients, on tumors that are being treated today. The PRAME data so far is based on historical samples. So you're either PRAME positive or PRAME negative. And so this is just looking at how all the patients who've been tested with the test since 2010, sort of the statistics. So overall, we see about 65% of the tumors have been class 1, about a third of those are class 1B, about 2/3 are class 1A, and then 34% have been class 2. And then since the last year, about 1,200 patients have had the PRAME testing done. And so about 2/3 of those have been PRAME negative, and about 1/3 of those have been PRAME positive. And that matches about what has been shown in previous studies by Dr. Harbour. So like Dr. Mruthyunjaya said, we're trying to maintain abreast of the new science and sort of progress as we learn more about uveal melanoma and the biology of uveal melanoma. And so like Derek mentioned, now that there are some known mutations in uveal melanoma, so this affects the DNA instead of the RNA. So we can actually sequence the DNA and look if there's any mutations in these genes. So in the next couple months, we haven't really talked about this too much, so this is kind of the first time we're announcing this a little bit. We are going to be looking at a 7-gene panel. And so this will be done with next generation sequencing, which basically means kind of the newer technology for sequencing mutations. These 4 genes are very common in uveal melanoma tumors. They're thought to sort of occur early on, but they can also be present in tissue and tumors that are not uveal melanoma. So it's not really a true diagnostic, but you would expect to have, most tumors will have one of these mutations. these mutations on the right, at least so far in retrospective smaller studies, have been shown to maybe have some prognostic value. But like Derek was saying, the gene expression profiling so far in comparison to those provides the best prognostic information. So, as we learn more, we just feel like it's important to have the opportunity from one single biopsy to be able to get as much information about each uveal melanoma as possible. Someone had asked about clinical trials, adjuvant therapy, so treatment before metastasis occurs. So there are actually 2 clinical trials that will enroll a high-risk class 2 patient that are ongoing right now. This trial here with crizotinib, they're enrolling at 4 different centers. The inclusion criteria does include both class 2 plus a large tumor, so greater than 12 millimeters in diameter. And then this top study is also ongoing. And there are specifics about when there's a window of time that you can enroll into these studies, so that's just something to keep in mind, that it's limited to where you had your definitive treatment to when you can go on a trial. And so we actually do provide clinical trial information, both for adjuvant treatment and then for treatment of advanced uveal melanoma. Primarily, we get this information from clinicaltrials.gov. We had been providing it mostly to physicians who've asked for this information, and we update it every 3 to 6 months. But if this is something that you as patients are interested in, we can certainly, we're actually updating our website right now, so we can actually put this on the website and have it updated. I would still recommend, you talk to your physician. We try to make it as comprehensive as possible, but sometimes this information changes pretty quickly, so it's just kind of a reference to start looking in the right direction. So I think that's all that I had on gene expression profiling. I guess we want to see what you all have questions about, if you want to share your experience with those of you who've had the testing done.
So once the test has been done and you come up with this new, what's it called?
PRAME.
PRAME. Can you go back then and look at his old biopsy to see if he has PRAME, or once they looked at it, it's too late?
So you've had the expression profiling done. So there are cases in the last couple years, so the methodology has improved for the gene expression profiling, where we used to have to use all of the sample. In later years, we've been able to, sometimes for some patients, we'll have leftover tissue that we could potentially do some of these other tests. So it really is on an individual case-by-case basis. So we would urge you to contact us, and we're here, or you can also email us or give us a call, and we can check on your specific case.
You mentioned earlier another lab called Impact Genetic.
Mm-hmm.
So what's the difference between us and?
Well, I think Dr. D'Amato is going to be talking about impact genetics. So that's chromosome testing. This is looking at the RNA, so the expression of genes. Chromosome testing is looking at copy number, whether chromosomes are gained or lost. But he'll definitely be able to provide more information. Mm-hmm.
I was just going to ask you to explain that a little bit. I don't think the average person, they're both nucleic acid
Yes.
tests, but the RNA is very different than DNA. Could you elaborate a little bit more?
Yeah, sure. So your genes are then, chromosomes are sort of the larger portion that contain your genes, and those are made of DNA. And then the DNA is the sequence. So then the DNA gets transcribed into RNA, which is really how much a gene is expressed or not expressed. So they are different. RNA is really reflecting the activity of the genes, where the DNA in the chromosomes is reflecting how much DNA is actually there, how much of that gene is there, and then the RNA is the expression of that gene.
So you can't take with the GEP, the samples you usually take for Castle are RNA based, so you don't have the DNA material in the tested after.
Well, actually, so with the sequencing, because the mutations look at DNA, whereas the GEP is off the RNA. But we've actually developed a method so that we can get both materials from the same biopsy. So we'll be able to have both the DNA for the sequencing and the RNA for the GEP.
So when would it be advantageous to go back and get the PRAME, only if you're in a class 2 or at any?
So, right, that's a good question. So, Dr. Harbour has published a couple studies on PRAME, and again, this is all, sort of still evolving. For class 1 patients, that was where he initially focused, looking at there are a few class 1 patients who will experience a metastasis. It's not a 0% chance. And so he identified that elevated PRAME expression might indicate which class 1 patients are at a risk for metastasis, kind of like what class 1B currently does. And right now the comparison is that we don't know which one is better, and that's part of the reason for this new study, to really look at that in a large number of patients. And for class 2 patients, the PRAME expression may indicate a higher risk of metastasis. So really it's applicable to both groups.
Clinically, we've seen, Dr. Hovland's here, so I can't speak for him, or Dr. D'Amato, but clinically we've seen many of the ocular oncologists who have begun asking for us to provide PRAME results at the same time, or using it sort of as a second checkpoint to determine surveillance regimens and et cetera today. The literature is far more robust or definitive on the gene expression profile accuracy, and while the PRAME data is interesting and can kind of fine-tune that, it doesn't say ignore this for that. That being said, if there's interest in saying, gee, you ran my tumor for gene expression profiling, I'd like to have my physician and I to have that data available, I would say the first thing is to either email Kristin directly or have your ocular oncologist contact us, and it's a quick check of the freezer to say, yes, we have tumor sample left, we can do it, or we can't do it.
And the other thing I didn't mention about PRAME is that one, I think, attractive thing about PRAME as a marker is that it actually is an antigen, so it becomes expressed on the surface of tumor cells. So potentially down the road, if therapies would be developed towards PRAME as a target, it could be a marker for that as well. But I will just say we're pretty far off from that. There are PRAME-directed therapies in other types of cancer that are being tested, but so far in uveal, there's melanoma, there's nothing. But that was sort of also an aspect of PRAME that's important, that it could potentially be a marker for therapy.
Question regarding the PRAME that you were just talking about. When a class 2 patient expresses PRAME positive, it talks about it could possibly indicate a shorter time period to developing metastasis. So what when you talk about a shorter time period, are you talking about, within 3 years, within 5 years? Are you talking within that first 3 years? It could be within the first 12 months. Do you have any data as to what that kind of represents?
Yeah, so far the data that has been published is all on relatively small cohorts, even for the class 2 patients. So it's really hard to make that determination of survival rates, metastasis-free survival rates and things like that. So that's really the point of the COOG-2 study, to be able to make those estimates of how quickly could a PRAME-positive class 2 tumor cause spread.
And I would take those last two questions too. So the reason for kind of rolling or making available this 7-gene sequencing test is in 2017 today, the most actionable data would be coming out of the gene expression profile results. The sequencing data is interesting but may not be overly actionable. So we've been a little careful last year not to be aggressive, saying, hey, we can do a bunch of things for you and create a bunch of confusion that actually means nothing until we make sure we understand better what it might actually mean. And so the cart's not quite in front of the horse is slightly ahead, but there's no ways the horse way ahead. So I think we're being a little careful about making sure that your physicians and you don't overinterpret what data you may have. Now that being said, most clinicians, I think, are taking just one biopsy that's available for downstream testing services. Most of those are coming to our laboratory. We're certainly in a position to say we should treat your specimen the best we can for the longest period of time, and if that means giving you information now that may be not very useful today, at least we can give it to you so it can be maybe useful tomorrow, as opposed to just say it's not available. So we're in a delicate place here about making sure that you have the most information you can, but also knowing that some of it may not be relevant, I guess, clinically to you personally.
I guess my question then would be, you decide to ask your doctor to go ahead and order, to call you, find out if you still have something viable to look at, to do frame testing. But then you come up with something in 6 more months. Have I now used up my only sample left so that the next test I can't do? Or,
Right.
you know what I'm saying?
I mean,
In theory, yes. I mean, it's very unlikely that in 6 months anything brand new is going to show up that we
Right.
don't. So theoretically, your question though, the answer would be yes. The more testing we do with your sample, it's limited, and the more we do with it, at some point we're not going to have anything to do anything with later. I think the question that you ask yourself as a patient is, do I want what we have in hand now, or would I want to conserve my sample in case something comes down the line, you know, way later, that may or may not be relevant to you at the time.
Right.
So it's just it's a personal question, but yes, at some point your sample is a finite thing, and you know, the more work we do with it, the less there is of it left. So it's a question you ask yourself.
You came in late, you just came back.
Yeah,
sure. Is it possible to get a copy of this, or is it available? It seems very blurry.
oh yeah, sorry, this is just an example. Of,
So these aren't actual
Yeah.
files that are going on?
They are, but it's just a snapshot of the actual list. So we provide these lists for, right now we've been providing them to physicians who've asked us to help compile this information, but we were saying we could certainly put this on our website, so they would be full-size PDFs, a list, and it'll have, you can see kind of probably, it has all the sites that are recruiting currently, although this changes, so again, it's important to go to the clinicaltrials.gov and check those, and then we'll try to put whatever contact information, phone numbers, emails that are listed on the website. And the trial number is actually hyperlinked, so you can just, if you're looking at this online, you can just click on the trial and it'll take you to the clinicaltrials.gov description, so you can see the inclusion criteria, who's recruiting, if it's still recruiting, things like that.
Who would my physician, who would my oncologist follow up with?
I mean, they can certainly contact me to get the list. We'll try to put these online soon as well. And then they would need to contact if there was a particular trial, there would be the contact information for the trials on there.
But you can also use tissue for metastatic disease biopsies now too, right?
That's a good question. We currently we only test, the test was developed only off the primary tissue, so off the eye tumor. With the sequencing, initially we'll be doing it off the eye tissue as well. Down the road we would have to validate on metastatic tissue to be able to offer that. So initially everything is off the primary.
So the
eye tumor.
metastatic tissue could be different from the primary?
Yes, it could be. Yeah, I think Dr. Harbour has looked at gene expression profiling in some metastatic tissue, and it does seem like there's some changes.
Would that be even more useful for targeted therapy down the road? Because that's a new expression of the...
Yeah, certainly. I mean, especially the mutations in the metastatic tissue could be important for therapies. So that's something that we will have to work on. You have to validate on each tissue type, so we'll have to work on the sequencing for that tissue as well.
Making a purposeful decision about whether or not to do the test and thinking about conservation of the sample.
Yeah.
Is there a shelf life of the sample that you should factor in there also then?
So the two analytes that we look at right now are RNA and DNA that we've been talking about. We store RNA and its byproducts in a -80 environment, -80 degrees Celsius environment. So technically that's stable forever. DNA, we all know, is very stable for many years. So there shouldn't be concerns about the stability of the sample.
Thank you.
So the tissue of all the samples you're getting are exactly the same. The only difference are these 7 genes that you mentioned, or there are other genes that were not discovered or still under investigation. It is.
I'm sorry, I don't know if I understood.
So because people say that there are thousands of mutations of cancer and so on and so on, but here you're talking about just 7 genes Is it because this is the only thing that was discovered? There are many more that we don't know about them, or
Right.
are under investigation. Where
Sure. So for the gene expression profiling, it's the 15 genes, and those were identified as kind of the most important for determining risk. And then PRAME came along. For the mutations, so there has been quite a bit of mutational work just looking at what mutations are present in uveal melanoma, and this has been done by many groups. And it doesn't, uveal melanoma is a little different from cutaneous melanoma where it doesn't have a lot of mutations. So it is thought that these are kind of the primary mutations. Not that there can't be others, but there aren't nearly as many as with skin melanoma.
One last question?
So for the people that you have, that are like 1Bs and you already have the tissue and didn't do PRAME because it was a couple of years ago, now you're talking about DNA. Are you going to take those tissues if you still have them and do a DNA? And then are you going to be able to have that stuff? Or is it going to be an extra cost? Is it covered by insurance? Is PRAME covered by insurance if you wanted to go that way? Do you know?
So if you've already had the gene expression profile testing done previously before PRAME became part of the scenario, we can revisit your sample in the lab if we have it, and we can go back and run it. There is an administrative fee that's patient pay. It's not something that is run through insurance. So if you want to get that, then we charge you this fee, and then assuming we have your sample, we'll run it and report it back to you and your physician. Moving forward, patients who have been prospectively tested, it's part of the GEP, basically the part of the GEP package. So, but yeah, you just need to speak to your physician if you want to go back and get that information retrospectively. And if you decide to do that, just contact the lab, contact us at the lab to make sure that we have some residual material, and then we can give you the specifics from there.
Do you have any approximation how much the administration fee would be?
No, the administrative fee is $450.
Okay. Thanks.
Great. And to continue the discussion on genetic testing, we're now going to have Bertil D'Amato come up and talk about some of his work on a different test.
Thanks. Hello again. I'm going to record this. This is the iPad I use when I speak to patients, and I usually email them the recording after, but on this occasion, I'm going to record this to send back to the people in the Impact Genetics team, who unfortunately couldn't be here, and they got in touch with me a couple of days ago to ask if I can give a presentation on their behalf. Now, I'd like to emphasize I'm not getting any income, and I never have received any income from Impact Genetics, and I don't expect to do so either, but my talk will explain why it's me that's giving this presentation. So as I mentioned earlier, I started, what happened was in 1996, a German group found that if there's loss of chromosome 3, monosomy 3, the mortality from uveal melanoma was very high. And if that mutation was absent, then there was no metastatic disease. So as soon as I saw that paper, I went to my hospital in Liverpool, and I said that if the patients ever find out that we're just treating their eye and not doing anything for the survival, they'll never forgive us. And thankfully, my hospital employed a full-time postdoctoral PhD to convert that paper from a research study into clinical practice. And only 3 years later, I started offering genetic testing to my patients in 1999. But that was with fish. But I wasn't too happy with fish because, well, I was at the time until we got some results, because I was checking all the results on all the patients. And I found that there were some patients who were dying despite being given a good, well, they weren't given a good prognosis because we looked at other factors too. But this test wasn't foolproof. So I was at this meeting in the Netherlands, a melanoma meeting in Holland. And I was distracted by this lady's beautiful hair. But I was soon distracted by a talk on MLPA, cutaneous melanoma. I'd never heard of MLPA. So I went back to Liverpool. Luckily, I was with Professor Copeland, who worked with me, a pathologist. I went back to Liverpool, and she learned the technique. She went back to Holland to learn how to do it with melanoma. And we set up a study to evaluate this technique. And I did this study. Luckily, I had tissue banked for 10 years from previous studies. And I was able to compare the survivors and the non-survivors. And I was able to learn how to interpret the numbers, because these laboratory tests give you massive numbers, which don't mean anything at all. The laboratory that had developed the MLPA in the Netherlands had never really used it very much with melanoma, so they couldn't tell us how to interpret numbers, and that's what I did. I learned how to interpret the numbers. And then a few years later, after using this test, I evaluated our results, and we found that they were much better than the fish results. Over there you can see, again, I can't see this. Over about 130 patients in the top line there, and none of the patients with disomy 3 melanoma developed metastasis. Since then, I think 1 or 2 have developed, but by the end of that study, which continued over many years, none of the patients with a good prognosis developed metastasis. So that encouraged us to continue using that test. But one of the things that is really important, and which Impact Genetics is doing, and I'm sure other people are doing, is correlating the genetic testing with clinical findings. Because, as I reported in the just after the year 2000, a few years later, it's not enough to do genetic testing. All the genetic test does, it tells you whether or not the tumor knows how to spread. But then there's also other features that are important. How quickly the cells are dividing, how long the tumor's been there, and all those kinds of things. So in Liverpool, we developed this program to combine genetic testing with tumor size, with mitotic count, with the division rate and under the microscope, with other microscopic changes. And this greatly improved our prognostication, so that we give an idea not only of whether or not the metastasis is going to occur, but when it's likely to occur. And as we've heard, there's new mutations being discovered more and more. And so since I've moved to UCSF, we've been evaluating a kit, a panel developed at UCSF using next generation sequencing, UCSF 500. And this looks at more than 500 genes, all the melanoma genes, all the uveal melanoma genes. And our results to date, we've been doing this now about 4 years, and our results are very encouraging. And Dr. Afshar is evaluating this as part of a thesis that he has to prepare. So like this, we're able to predict survival, combining the genetic testing with the clinical features, TNM staging, histological grade of malignancy, and so on. So Impact Genetics have asked me to say that these are slides that they've prepared, that they also test for BAP1, because as we've heard at a talk just a few minutes ago, very rarely this runs in families, and so they are testing, they're offering this test to look at the germline mutations in these families, and these tests will give an indication of what investigations relatives might need to have, and so on. But as we heard in the genetics talk a few minutes ago, it's not enough just to do the test. You have to have a lot of counseling, before doing the test, when the test result comes, you've got to select whether or not to do the test. The same test might be good for some people and bad for others. When I started doing genetic testing in 1999, I wasn't aware of anyone else having done that test. So there were no guidelines I could follow. And so what I did, I searched the literature and I found guidelines, Canadian guidelines for HIV testing. And I followed those guidelines with uveal melanoma to learn what to say to patients, how to make sure they were fully informed before deciding whether or not to have the test. And then they had further counseling after they had the test, but before they had the result. And then they had more counseling once the result became available. So it's not a simple thing of just doing a genetic test. You need to be fully informed to decide whether or not the test is good for you or not good for you. And then there's all the implications that you need to know about. That's what informed consent is about. And that's the service that's being provided. So if you have any questions, please get in touch with them, because I don't work for them or anything like that, and they can answer their questions much better than I do. I'm just an eye surgeon who's finding this very useful, and I can't see very well either. Thank you very much.